First, we will hear from Dr. Katie Moise. Dr. Moise graduated from UNC Chapel Hill with a bachelor's degree in exercise and sports science and psychology. She then went on to pursue her doctorate of physical therapy at Emory University. She has advanced training in pelvic health through the Herman and Wallace Rehabilitation Institute and also received her comprehensive Pilates training through Polestar Pilates. She founded ATL Pelvic Health in 2021 after recognizing the need for pelvic floor physical therapy specialized to women's needs. With ATL Pelvic Health, her goal is to educate, provide resources, and guide people through caring for their bodies. Although she treats clients, including men, across all stages of life, she's proud that ATL Pelvic Health is changing the care available to new moms. Dr. Moise hopes that you can return to the activities you love, and her talk is titled From Injury to Recovery, Managing OASI for Long-Term Pelvic Health. Next, we will hear from Dr. Julie Cantor. Dr. Cantor practices civil rights law and advocates for birth rights. She holds undergraduate and master's degrees from Stanford University, a JD from UC Berkeley's Law School, and an MD from the Yale School of Medicine. She was also a visiting student at Yale Law School. For over a decade, she served as a member of the adjunct faculty at the UCLA School of Law, where she taught an upper division seminar on reproductive rights, medical ethics, and the law. Over the past 2 decades, Dr. Cantor has written and spoken about issues that arise at the intersection of medicine, ethics, and law. She has been the grand round speaker at numerous medical schools and hospitals across the country, and her writing has appeared in various academic journals, including several publications in the New England Journal of Medicine. In recognition that those harmed by violations of consent and other forms of obstetric violence should have access to the justice system, she's added litigating obstetric violence cases to her law practice. Her talk is titled Your Right to Consent and to Decline Care During Birth. Finally, Kaylee Summers, a licensed therapist, writer, and content expert in perinatal trauma, was going to be here to share her wisdom with us, but unfortunately, she's fallen ill and is unable to present today. Her talk, titled Beyond the Delivery Room, Understanding and Managing Perinatal Trauma After OASI, will be recorded at a later date and embedded within the webinar video that we post. So when we do post this recording, you will still have the opportunity to hear from her and hear her session, which is absolutely invaluable for providers, advocates, and women. Without further ado, Dr. Katie Moise, please start us off.
Awesome. Hold on. Let me just turn on my video. Oh,
We hear you though.
okay, I'll go ahead and start talking. Sorry, I don't know why my video isn't turning on. Oh, here we go. So okay, awesome. Thank you, Amanda, for that introduction. As she said, my name is Dr. Katie. I am a pelvic floor physical therapist, as well as the owner of ATL Pelvic Health, which is a pelvic floor clinic here in Atlanta, Georgia. And my passion really lies in working with women during pregnancy to help manage any symptoms that might pop up during pregnancy, whether that's low back pain or hip pain or stress incontinence, and also help women prepare for birth and then also transition then to that postpartum recovery phase. And so what I want to talk to you guys today about is the long-term management of your pelvic health after these obstetric anal sphincter injuries. And so I think first, to kind of orient ourselves to our pelvic floor in our body, if you take a look at the picture on the right, we are looking at your pelvic floor kind of up underneath the hips and pelvis. And our pelvic floor is a group of muscles that are running from our pubic bone in the front and wrapping all the way around to the tailbone in the back. And we can think of these muscles as a sling or a hammock, and they play a lot of important roles in our everyday function. So these muscles work together to provide sphincteric control for both bladder and bowel function. So they're keeping urine and stool inside of our body until it's time to eliminate. They also play a huge role in sexual function, so ability to orgasm, arousal, and pleasure. In females, the pelvic floor is helping to support all of our internal organs inside of our body. And so we have our bladder that's sitting in the front up against our pubic bone. We then have our uterus and our rectum. And our pelvic floor is literally, along with fascia and ligaments and connective tissue, helping to support these organs inside of our body. The pelvic floor also is playing a big role in core support and stability. So our pelvic floor works with our diaphragm and some deeper core and spinal muscles to help provide support so that when we reach in the cabinet to get a cup out of the cabinet, or we bend over to pick up something heavy off the floor, these muscles are working to provide support so that we're not having any extra pain. And then lastly, these muscles help to pump fluid back up into our circulatory system, so they act like a sump pump. And so the muscles of our pelvic floor are going to be affected throughout pregnancy, regardless of the way that we give birth. They're going to go through changes, lengthening and getting a little bit weaker just from the weight of our baby. And then when we start to think about these third and fourth degree tears that happen after a vaginal birth, we're going to see a lot of different symptoms that can pop up affecting both our bladder, bowel, and sexual function. So we've heard from some of our speakers already about how common it can be to experience stress incontinence, which is the leakage of urine with sneezing, laughing, coughing, running, or jumping. Fecal incontinence is also going to be really common. Again, because these third and fourth degree tears are impacting not only the perineal body, which is the space between the vagina and the anus, but they're also going to start impacting our external anal sphincter, which is a muscle that wraps around the opening of our anus and into the anal mucosa. And so that can definitely start to contribute to some of those bowel symptoms that we've heard about as far as fecal incontinence goes. So that can look like fecal smearing, which can be like excessive wiping when you're having a bowel movement. It could be noticing some smearing of stool in your underwear. It could be full loss of your bowels. Also, just difficulty holding back gas. Again, because of these injuries, when we have that repair, anytime there are stitches or trauma to our tissues, there can sometimes be pain that is related to that. And so commonly after these injuries, we can see not only just pelvic and perineal pain, which may present as pain with sitting or standing or certain movements, but that can also start to impact pain with any type of penetration. So if you're using any menstrual products, if you're going for a gynecological exam, if you're having penetrative intercourse with a finger or a penis, the decreased pliability of the muscles in that tissue after repair can sometimes lead to pain with that. And then again, because these muscles have been impacted after vaginal birth, we can also see them no longer really being able to do the job the way we need them to do and holding things up in our pelvis. And so we can start to feel an excess like heaviness or pressure in our pelvis. Some patients will complain of things like feeling like they're falling out. And so these are all things that we're going to work with people on in pelvic floor therapy. Okay, next slide, Amanda. Okay, so kind of talking through our pelvic health and how we can really optimize our pelvic health after these injuries, the first thing I wanted to touch on was bowel health. This is going to be one of the most common complaints people are experiencing after a grade 3 or 4 tear. And bowel health is really, really important for overall pelvic health. Our bowels in turn affect our bladder and just our overall function of our pelvic floor muscles. So one of the biggest things that we're going to focus on in early management of these injuries is constipation. Because the pelvic floor muscles are really vulnerable right after giving birth, we really want to avoid any excess straining or pushing on our pelvic floor. And so typically when people are constipated, they're going to be bearing down, like holding their breath, putting a lot of pressure to try to have a bowel movement. And we really want to try to avoid that extra pressure on our pelvic floor. Things that we're going to focus on for that right off the bat are going to be both fluid intake and fiber intake. For fluid intake, we're recommending for people to be drinking at least half their body weight in fluid ounces each day. If somebody is producing breast milk, that fluid recommendation actually goes up towards closer to 100 ounces per day, because so many of our resources of fluid intake is given to making breast milk, then we can still sometimes end up dehydrated, which can lead to our stool being more firm and harder to pass. We also want to think about fiber intake. And so with fiber intake, the main takeaway here is that stool consistency matters. We want your stool to be soft, again, to make it easy for the stool to be eliminated out of your body without excessive straining or pushing, but we don't want it to be too soft. Because the external anal sphincter muscle that, again, wraps around the anus has been disrupted, if the stool is too soft, it requires the muscle to work harder when you might not have the strength in that muscle right off the bat to keep that stool inside of your body. And so if the stool is too soft, that might increase the chances that you're dealing with some fecal incontinence. And so our target here is for stool to be kind of like a nice sausage where it's firm but soft, it's stuck together. And so we do want to be mindful of our fiber intake. Typically, when I'm working with clients on their fiber intake, we're encouraging ways to add fiber to things that they're already getting in their diet. And so, can we incorporate nuts and seeds as a snack or add avocado to a salad because avocados are great sources of fiber? Can we switch from white grain to whole grain bread? Sprinkling chia seeds onto a yogurt bowl or a smoothie bowl or into oatmeal or something like that. Chia seeds are great because they're a good source of fiber, but they also help the stool stick together so that we are getting well-formed stool, but keeping them soft. Other things that we want to consider when we're thinking about our bowel health is we want to avoid straining or bearing down. And so we really encourage people to practice exhaling as they're pushing for their bowel movements to avoid that Valsalva grunting and holding their breath to really have that effort behind pooping. And then lastly, we want to think about toilet positioning. So using a squatty potty, which I'm a huge fan of, or if you have an extra stool around your house or yoga block or a thick book, something to put your feet on so that your feet are supported, but that your knees are above your pelvis is going to put your pelvic floor in a more relaxed position so that the stool can just move more easily out of your body without that excessive straining and pushing that we're trying to avoid. Next slide. Other things that we want to consider for overall pelvic health. I am definitely biased as a pelvic floor physical therapist, but I think early intervention is key. There is so much that we can do to kind of help your body recover after these injuries. And unfortunately, in the United States, we're a little behind the 8 ball on this. In many other countries, it is a standard of care that pelvic floor therapy is kind of an automatic referral after childbirth, regardless of a vaginal or a cesarean birth. If you think about having an ACL tear or a rotator cuff injury, those are automatic referrals to physical therapists for rehab. Yet when we birth a baby, we are usually left with very little guidance after that 6-week follow-up appointment. And pelvic floor therapists can really bridge the gap on that. And so what we are working on with people in pelvic floor therapy is scar mobilization. Again, if that scar is kind of sticky and the scar tissue is laying down and not being moved around, it can lead to a lot of pain, and that can be what leads to painful intercourse. We're going to be talking with our clients about how to optimize their bladder and bowel habits. So we spend a lot of time going over defecation dynamics, so how to poop well without straining or putting pressure on your pelvic floor, how to breathe, going over nutrition, stress, all the things that can impact bladder and bowel health. And then we also want to start integrating the coordination and movement of your diaphragm with your pelvic floor. So the diaphragm sits underneath the rib cage and your pelvic floor is sitting in this bowl in your pelvis. And these two muscles are working as a system to provide that support and stability to your body. And so your breathing changes after giving birth because your rib cage position is going to change to accommodate space for your baby while you're pregnant. And so if we can reconnect with your breath and reconnect with just kind of turning those pelvic floor muscles back on so that they know what their job is, that can be really powerful in your recovery to, again, try to prevent some of these symptoms from popping up. We want to then start to incorporate functional strength training. So just doing a bunch of Kegels on your back is not going to be enough. We want to think about how can we integrate these movements and the strengthening of your pelvic floor into your everyday life. If you're a new parent or you have older kids at home, you know that you're going to be lifting car seats and strollers and toddlers and grocery bags and all of these different things. And so we want to make sure that your pelvic floor has a strong foundation to be able to support you through that without having symptoms. One way that we do that is going to be a lot of time talking about how we breathe. And so similar to with bowel movements, with wanting to avoid holding our breath, we also want to think about, can we exhale on the exertion or the effort of a movement to help the pelvic floor kind of lift and support us without putting that excess pressure. So a lot of times we'll coach breathing out when we stand up from a squat to help, again, the pelvic floor to lift and support us through these movements that we're doing throughout our day. Next slide. So, when should you see a pelvic floor therapist? As I said, I'm very biased. I think everyone should see a pelvic floor therapist after giving birth. I think it is really integral to build the foundation of how is your body responding after birth? What are your muscles doing in terms of can they contract? Can they relax? Your pelvic floor doesn't work in isolation. So, we want to see not only what your pelvic floor is doing, but how is your abdominal muscles healing? What's the strength of your abdomen? What are the strengths of your hip muscles, your back muscles? All of that is going to be integrated together to really optimize outcomes. Um, these are some symptoms that we have heard from other speakers about, and I've touched on briefly that are definitely red flags where you should seek help. If you've been dismissed by a medical provider, we as a society definitely normalize a lot of these symptoms, like, oh yeah, you can't hold back gas, or you leak a little when you cough. Like, that's normal because you've had 3 kids, or just have a glass of wine and relax and like sex won't be painful anymore. Those are not helpful comments. And I want to just kind of validate that these symptoms are really, really common. A lot of people are experiencing these symptoms, but they're not normal. And intervention with a pelvic floor therapist can really help manage a lot of these symptoms. So any kind of leakage that you're experiencing, urinary leakage with laughing, coughing, sneezing, any increase in urinary urgency and frequency, so feeling like you have to run to the bathroom all the time, any stool leakage, so difficulty holding back gas and stool, and any kind of pelvic pain. So that can be pain with intercourse, but it could also be unresolved tailbone pain, hip pain, low back pain, pubic bone pain, things like that. Next slide. And so when you're looking for a pelvic floor therapist, how do you know if you found one that's right for you? Just like every doctor is different, every chiropractor is different, every pelvic floor therapist may have a little bit of a different philosophy when treating these clients. We really believe that when you're looking at the pelvic floor, we need to be looking whole body. So we want to be looking head to toe to see how the pelvic floor is responding and integrating with all of the other muscles in the body. If you are comfortable and you give consent and it's warranted, the pelvic floor therapist should be able to do both an external and internal assessment, either vaginally or rectally, to really get a strong understanding as to how those pelvic floor muscles are functioning and healing after childbirth. We believe one-on-one time with them, spending a full hour so that we have time to hear our clients' stories, understand what their goals are, and work with them as a team to get them back on track and to develop a specific and individualized plan to help them reach those goals. And then, as I mentioned earlier, it's way more than just doing Kegels. So if you have been seeing a pelvic floor therapist and you don't feel like you're getting an improvement in your symptoms, and you've just been lying on a table hooked up to a biofeedback machine doing a bunch of Kegels, there's way more out there that we can be doing as pelvic floor therapists. And so you may want to just start asking questions about how you can make those exercises more functional for you. Next slide. And so lastly, I just wanted to briefly touch on future considerations for pelvic health. We had some questions and we've touched on this already a little bit in the Q&A section. One about transitioning to perimenopause and menopause, the other one about future pregnancies. For future pregnancies, I think the ultimate conversation comes down to what your OBGYN and or midwife thinks is the most safe for you. If you have sustained a grade 3 or 4 tear, we definitely as pelvic floor therapists have worked with clients that have had tears and had subsequent vaginal bursts, where we want to start working with them earlier. Assessing their perineal body length is important to know if there's a risk for increased tearing. We can start perineal massage and different manual techniques to the pelvic floor muscles to help with that as well. And then helping them prepare their body for birth, teaching them how to push effectively. So a lot of people actually don't know how to push. And so they show up to their birth for the first time as if they're running a marathon without actually training. And so that can sometimes lead to longer pushing times, use of instrumentation, all of these things that may lead to an increased risk factor for a tear. And so there's no guarantee with the work that we're doing in pelvic floor therapy, but we can definitely be proactive in trying to prepare the body for birth. As far as perimenopause and menopause goes, we know that regardless of birth history, 1 in 5 women as they transition into menopause are going to experience some level of fecal incontinence. And this is due to that drastic drop in estrogen levels. And there are a ton of estrogen receptors around the anal sphincter. And we know that the anal sphincter is being impacted by these grade 3 and 4 tears. And so for women who are transitioning into perimenopause or menopause, we may want to reach out to the provider to talk about an estrogen cream that can be helpful to kind of plump up the vaginal tissues, which is going to then impact the function of the muscle. This can also be important for people who are breastfeeding because we see that drop in estrogen when people are breastfeeding as well. But if we can get early intervention with pelvic floor therapy to really set a strong foundation with their pelvic floor health, the bowel symptoms and the urinary symptoms that will sometimes start to manifest in perimenopause and menopause can really be mitigated if we are being proactive with people's pelvic health on the front end. So I will pass it back to Amanda for questions.
Thank you, Dr. Moise. And actually, before we dive into Q&A, we are going to have Dr. Cantor share, and we'll do a combined Q&A after Dr. Cantor. Go ahead when you're ready, Dr. Cantor. And thank you, Dr. Moise. That was excellent. We got some good questions.
Thank you so much. Thank you, Dr. Moise. Thank you, Amanda and Caroline and everybody. Everybody who's here in the audience for being here, and Amanda and Caroline for spearheading this effort and SOLACE in the first instance. I want to just turn to my slides for a second. Give me 1 minute. Here we go. So I am going to talk about these issues of consent, and I have 3 stories to share with you about the law. Here we go. So the first story, and the reason that I want to tell you 3 stories is for the following reasons. 1, because you can't defend your rights if you don't know that you have them. So one of my concerns here and one of my goals is to share with you basic information about your legal rights in society, but also to let you know that these rights may not be respected in certain communities or certain facilities or even certain courts. And so you have to do your due diligence. On the other hand, a lot of what can happen in the clinical setting can turn on knowledge, information, power dynamics. So one of the goals is if we as patients and the healthcare community and the legal community understand these rights and the thinking behind them, that we can all be supportive and on the same page rather than have some kind of a conflict in the birth setting, because that's really not going to be helpful for anybody. So through this, I want to get closer to the goal that we all have of a respectful birth care, and similarly eradicating obstetric violence where people feel like they've been traumatized, their rights have been overridden, or they were coerced into something that they really didn't want to happen, and it wasn't an experience that should have happened to them. So I'm going to talk about these 3 stories and a couple of other ways that I think you can educate yourself, and then we'll go into questions. So beginning with the 3 stories. The first one is the case of a woman named Mary Schlowendorf, and this is a case very famous. It is actually a cornerstone of informed consent legal doctrine from New York in 1914. And this is a woman, you can see her in this drawing, who was admitted to this particular hospital in New York for what was described as a disorder of the stomach. And the doctor said, well, we need to examine you under ether or under anesthesia to be able to really understand what's going on. So let's take you to the operating room and do that exam under anesthesia. She said, okay, she consented to it. At least that's the position of this case. There was, as a footnote, perhaps some conflicting testimony, but the way these things work on appeal is that you give the plaintiff the benefit of the doubt. So let's assume that she consented to the ether anesthesia. And she said specifically, I don't want an operation. I do not want an operation, whatever her reasons were. So she was taken into the operating room, and a fibroid tumor was discovered, and against her wishes, it was removed while she was under anesthesia. Unfortunately, she developed a complication, which was gangrene in her left arm, and some of her fingers had to be amputated. So she said she didn't consent to this, and that wasn't okay, and she brought a lawsuit. Now, a lot of law is made through statutes where our legislatures, whether they're federal or state, pass laws. And then sometimes those are argued about. What does that mean in court? This particular case is an example of what's called the common law, which is judge-made law, which is judges saying, want our society to be? What are our rights in American society? What does this mean to us, and how can we establish a rule going forward? And that's what's the value of precedent. As you know, there's a rule, and then the idea is that you adhere to it going forward because the issue has been resolved. So again, here we are in 1914, and this is, let me turn to Justice, hang on one second, turning now to Justice Benjamin Cardozo, who was on the highest court of New York and then elevated to the Supreme Court of the United States. So a very esteemed jurist. And what he said was, in his opinion, that every human being of adult years and sound mind has a right to determine what shall be done with his own body. And a surgeon who performs an operation without his patient's consent commits an assault, known in other jurisdictions as a battery and unconsented touching, for which he is liable in damages. That means you can go to court and have money exchanged because your rights were violated. He also said, and this is speaking for the court, this is the highest court in this opinion, this is true except in cases of emergency where the patient is unconscious and where it is necessary to operate before consent can be obtained. So the guiding principle here is that you have the right to control your body. You get to make decisions about your body in a medical setting, and this is a cornerstone of American law and medical ethics. And indeed, your legal rights include the right to make a voluntary and knowledgeable decision about your medical treatment. You can see on this slide with me, your clinician must disclose your diagnosis, your proposed treatment, the risks, benefits, and alternatives, including declining all treatment, like doing nothing. There are some exceptions to this that you can see here, and we can talk about those in the Q&A if you have any questions about those. Moving forward, what do they have to tell you? That varies depending on your jurisdiction, which means your state. In some states, it's the reasonable physician standard. So that means what the doctors generally would want to tell their patients. Of course, the problem with this is that you don't really have a lot of recourse if the patients want certain information and the doctors are like, well, we don't think that information is reasonable to give you. So in some jurisdictions, the standard is, well, what does a reasonable patient need to know to make an informed and voluntary decision? And you can see a map that gives you a sense of how these standards are across the country. And that's a little bit of a deeper dive, but just know that that's out there and that you may need to understand that in your state. But generally speaking, as a baseline generality, here is sort of a summary of your legal rights in the healthcare setting. You have the right to understand the pros and cons of an intervention. You have the right to understand other options, including doing nothing, to have your questions answered, and to not be threatened or coerced into agreeing. So I want to move on. And as I mentioned, unconsented touching is illegal. It's a battery, and frankly, it's also a crime. I am not aware of any prosecutor bringing cases for unconsented touching in a medical setting. We can talk about that in Q&A as well, but it is in terms of the normative value, like how we're supposed to be running our society. We're not supposed to be invading people's bodies without consent. So let's turn to the bigger question, which is what about during birth? And so that brings me to my second story, which is the case of Robert McFall. So this is the story of a man. He's the one I don't know if you can see my mouse, but he's the patient sitting here. And he had cancer. He had a particular kind of cancer called aplastic anemia, and he needed a bone marrow transplant. This was back years ago, almost 50 years ago in 1978. The bone marrow transplant itself had few risks to the person donating the bone marrow, and he went through his family to try to find a person who could donate because they were a bone marrow match. So he kind of amazingly had a cousin who was a match for him. And his cousin first agreed to donate the bone marrow, and then decided he wasn't going to. There's a report in People magazine from 1978. I don't know if you can see it. I have that actual magazine. Thank you, eBay. Where it was reported that the wife didn't want him to do it. There were some family dynamics issues. But the point of the matter is, he said, no, I'm not going to donate to my cousin. So the cousin said, well, I'm going to die without your donation. So I'm going to sue you so that I can take your bone marrow and have somebody go get it for me because I'm going to die. And that came to court, and the court said the following: for our law to compel defendant, that is the cousin with the matching bone marrow, to submit to an intrusion of his body would change every concept and principle upon which our society is founded. To do so would defeat the sanctity of the individual, and it would know no limit, and would impose a rule which would know no limits, and one could not imagine where the line would be drawn. How would you enforce this? Would you go to his house and arrest him? How would that work? And the court said that morally, the court found this indefensible, that you wouldn't just donate your bone marrow to your cousin. But in the view of the court couldn't do anything to force that to happen because our society, and there are other societies, and if you were starting society over, you could have a different one. But in this society, at least as of that date, the respect for the individual was paramount, and you cannot go get his bone marrow. So that brings me to my third story, which is the case of AC from 1990. And this is a case it's very sad, where a pregnant woman had a recurrence of cancer. She was terminally ill, and she had a viable but premature fetus. She and her husband decided she did not want to have a C-section. If she was going to pass, she was going to pass with the fetus. The fetus was 26 weeks. At this time, there was a thought that the fetus was going to, once born, would pass anyway. And they decided that it would also hasten this woman's death if she had a C-section. The hospital sought a court order to order her to undergo a C-section, and it got it. So she did undergo the C-section forcibly against her wishes, against her husband's wishes, who was her surrogate decision maker in the event that she was unable to make a decision. And that was brought to court. She passed, and her fetus passed. They both died subsequent to this surgery within days. The issue was the hospital right, and was the lower court right in issuing a court order? And so what happened here is that this issue went up to one of the most esteemed courts in this country, which is the DC Circuit Court of Appeals, just by happenstance that she delivered in this DC hospital. And the court looked at the rule of Shimp, which we just talked about, and you can maybe see it here on the slide, where the common law, which is the judge-made law, has consistently held that you don't have any duty to save another person. We have the sanctity of the individual example. And the court acknowledged that there are some people out there who have advocated that because you're pregnant, you have special duties to your fetus, including the duty to give over your body in any way necessary, whether you like it or not. And this court, which was an en banc panel, which means a whole panoply of judges, more than 3, wrote that we wouldn't do that in the event that a child needed a kidney transplant. We wouldn't go get the kidney from its father, basically. So how can a fetus have more rights than a person who has already been born? Here, my underlining: surely, however, a fetus cannot have more rights in this respect, forcing invasions of somebody's body superior to those of a person who has already been born. In other words, if we're not willing, sorry, that was the kidney transplant picture, but if we're not in our society going to do that, where we go get organs or bone marrow from cousins, from moms, from dads, to save other relatives, other babies, other children, how can we impose that special burden on pregnant women, pregnant people, just because they're pregnant? It would elevate fetuses to have super rights, more rights than people who have already been born. Now, I want you to be aware there are cases where physicians have indeed imposed interventions during birth without consent, both with and without a court order. Here is one of those cases. This is the case you may have heard of Renate Dre. She had a forced C-section. She continues to litigate that forced C-section. It occurred 10 years ago. These are difficult lawsuits. You also have people advocating for equality under ERA, which they believe would make clear that all women have the right to their body. You also have patient rights, and there's an argument that if you don't adhere to patient rights as put up on the wall in a hospital, that you're doing some kind of fraud. That people go to your hospital and say, well, wait a minute, I have these rights, I'll come in and that's fine. And then if those rights are violated, how is it not that the hospital's committed fraud? Regardless of the law, doctors need to adhere to their code of medical ethics. And their medical ethics is based on autonomy, beneficence, which is the idea of doing good, the idea of non-maleficence, which is the Hippocratic do no harm, and the idea of justice, that we treat similarly situated people equally. And it's based on thoughts from philosophy and law. So ACOG, the overarching body for obstetricians and gynecologists, which not every obstetrician gynecologist belongs to, and not every obstetrician gynecologist is going to follow. But ACOG does say that you have the right to shared decision making and that your choices should be intentional and voluntary, including refusal of care or treatment, and that includes during pregnancy and delivery, that pregnancy is not an exception to that principle. A decisionally capable person has the right to refuse treatment, even treatment needed to maintain life. Now, you believe your rights were violated. What happens? You have the option to litigate. There are some realities about litigation that we can talk about in the Q&A, including the difficulty of getting a lawyer. It generally turns on how harmed you are. There are options for government reporting that may or may not continue to exist. There was recently a federal inquiry of Cedars-Sinai after the Kira Johnson death, and there was a question of patients of color being mistreated. There was a recent settlement about that. You can report to the media. Here are 3 articles with the word traumatic regarding a birth experience in various publications, trying to get the word out and for people to educate and prepare themselves. You can do grassroots organizing like we're doing now. You can do advocacy. Here on the right is a book of art put together by a pelvic surgeon who's watched women with postpartum PTSD due to what he thinks are all kinds of unnecessary procedures. Kimberly Said No talks about an unconsented episiotomy, and it's a play. Learn about the system and your options. Here's one way. Here are 10 films. I'm going to buzz through these. If you want them, I'll give them to you, the information. Here are 12 books. Here are 12 more books. Here are 11 more books, all about birth in this country. Here are academic articles about respectful maternity care and obstetric violence. This has been an issue since the 1950s when Ladies' Home Journal published an article about cruelty in maternity wards. So some of this is you get kind of acclimated and it's all normalized, like this is just the way it is. Doctors know best. Childbirth is dangerous. Motherhood's about sacrifice. But you have the power to learn about birth, to ask questions, to explore your options, to get advocates, to know your rights, to say that you declined, because the more you know about your rights, the better you are equipped to protect them. And what I wish for you is an informed birth, because that to me is an empowered birth. Know what your setting is, know where you are, know what you need, and know what you want, and know what your options are. And sometimes just saying to somebody, I know I have the right to refuse care under this statute or this rule or this ethic or this patient right on your board. Sometimes that can be enough. I've had personal experience with that. And of course, that is not data, but it can be powerful. I look forward to your questions. Thank you so much.
Thank you, Dr. Cantor and Dr. Moise. We have time for Q&A. So I did see some questions already come in, and I would love to throw them over to you. And to answer the last question in the chat, yes, we will share this webinar out, and I know Dr. Cantor is happy to share those books and films with you all.
Yeah,
So
just sorry, just really quickly. I'll naturally we can keep going. Sorry.
no, that's fine. I know people are excited about it. Dr. Moise, can you elaborate a little bit on what it means to have a low residue fiber diet? Is this soluble, non-soluble fiber? What does this really look like? Is Metamucil a good option?
Okay, those are all good questions. I try to simplify fiber as much as I can because I think we can get really bogged down in the insoluble versus the soluble types of fiber. I think when they were speaking about the low residue fiber earlier, if we have too much fiber in our diet and we're not balancing that with enough fluid intake, that can actually slow down stool moving through our GI system and can make our stool harder to pass, which again, we want to avoid after these injuries. So, if you're increasing fiber in your diet, you want to make sure that you're also matching it with increased water intake. So if you're not somebody that's drinking enough water already, before you add fiber into your diet, you want to focus on your fluid intake. And then when I think about fiber and I explain it to patients, I kind of think about all fiber as good fiber because it's going to help our stool consistency. What you want to be mindful of is that types of fiber too can also make the stools too soft, which I spoke about earlier, where it's like if the external anal sphincter has a hard time keeping stool inside the body and the stool is too soft, it's going to have an even harder time. So we want to, that's why like chia seeds, which kind of help balance out those types of fiber, can kind of bulk up the stool a little bit. Is kind of how I approach fiber with people.
Great. And what's the typical amount per day that people should be aiming for?
Yes, great question. So we typically say 25 to 35 grams per day, which is a lot. You have to be really, really intentional to get that number. Other ways that I help clients kind of navigate getting fiber in their diet, like a quick and dirty way, is adding some dried prunes after every meal, if you don't mind the taste of prunes. So that can just be like a, especially if you're early postpartum and like thinking about what you're eating is not at the top of your mind. Just adding in those dried prunes can be a nice way to get some fiber so that we can keep stool soft and moving regularly.
Great, thank you. And then some other folks were asking about, long-term care with pelvic health, about how many sessions should somebody who suffered an OASI, or even just anybody who needs to work on their pelvic floor, how long would you say we should be engaging in sessions with our pelvic floor physical therapist?
Yeah, the unfortunate answer is that it kind of depends. It's definitely going to depend on the type of injury you had, your birth history, your goals, and your symptoms. What I will say that can be a little bit more helpful is that when we start working with our patients, we try to see them weekly in the beginning so that we can really start to get some momentum and see that we're making change in whatever brought them into our office, whether that's urinary leakage, fecal incontinence, etc. So we tell our clients that you should be seeing improvements in symptoms in 3 to 5 visits. At that point, once we're kind of getting some symptom resolution and we have started kind of getting to the root cause of what's really driving all those symptoms. So, is your pelvic floor too tight? And is that because there's some decreased hip and core strength? And we need to kind of work on balancing all of those different muscle systems out. Once we've kind of gotten that plan, we start to decrease the frequency of our patients. But then our ultimate goal is that we're setting them up for success long term so that they're not back in our office in like 6 to 12 months with a return of symptoms. So we want to really build them up to make sure their body is resilient for the long haul. So that might look like seeing our patients even less frequently, but maybe periodic 1 month, every 3 month check ins. If we see somebody early postpartum, I like to give them the kind of like baseline of like, we're going to be with you kind of like a primary care provider for at least the first year of your postpartum life. That is not going to be every week for the first year, but I want to have touch points with you to make sure that as you're increasing activity or you're doing more or things start to shift or change for you, that we have laid down that foundational work so that your pelvic floor is in a good spot and these symptoms don't pop up.
Thank you. And then a similar question, and then I'll switch gears to send you some questions, Dr. Cantor. Recommended timeline to wait to conceive after pregnancy, and if you can even add after a severe tear, what would you recommend?
So this would be a good question for your OB. I would say typically we are wanting like a full year before trying to conceive again, because it really does take a year for your body to fully recover after birth. And I would argue even after a year, there are still changes and shifts in your body after being pregnant and giving birth. So I would say at a minimum of a year for like allowing your tissues to heal and for your body to kind of be ready to carry another baby. You might get different answers from your providers. I know a lot of people do end up getting pregnant earlier than that first year mark, but I think just from like a tissue healing, muscle healing perspective, giving your body a year to recover is important.
Thank you. Great. Dr. Cantor, some questions about legal action and advocacy.
Mhm.
How is there like a statute, of limitations when a person who has felt violated or lacked information or lack of care during their birth experience, how long can they consider their options?
So generally, there are always statutes of limitation, except for things like murder, where
Hmm.
there isn't. And it depends on what's called your claim or your cause of action and your jurisdiction, your state. So, for example, say that you said, well, I was touched without consent. That's a medical battery. So that would be your claim. And then you would say, okay, well, how long does that work in my state? So that's what you would need. And so generally, that could be 3 years. In some places, it's 1 year. One of the reasons why there's such an issue and the litigation in the Renat Dre case has been ongoing is exactly because of that reason, that there's a statute of limitations problem, that she missed the statute of limitations for battery, but she was in the statute of limitations for medical malpractice. And the hospital was like, we didn't do anything that's a violation of medical malpractice. So that's going to depend on where you are and what your claims are. I mentioned a fraud claim. That is totally beyond medical. That's different than medical malpractice. It's different than battery. Could have a 4-year statute of limitations, could have a 1 year. I don't know. It depends on your jurisdiction. And I saw that, and I don't want to jump, but I did see that there was a question about, well, what if you
Hmm.
discovered this late? You're
Yeah.
7 years out, but you just found out. There are principles in law that account for that, that say, well, your statute doesn't start until you knew or should have known. And so you're going to be up against a system that's like, your defendants will say, obviously, well, you should have known. You had this
Hmm.
sign and this symptom and this, so you should have known. So your statute started 5 years ago, not, today. So these are all things kind of unfortunately that, unless it's a mediation kind of thing where it's like everybody comes to the table saying, let's figure out a resolution. And it's more of like a litigation where we're just going to go into the Roman Colosseum and battle it out for however long it takes. You're going to have all of these battles going on, battles about statute of limitations, battles about when you should have known. But it doesn't mean that you should not look into these things. You should. You should look into them. You should talk to people, talk to different lawyers, just like you talk to different physicians or different midwives about your care options. Because in this setting, unfortunately, at this moment, there's this sense, and this is from me, that the idea in Latin in medicine should be primum non nocere, which is do no harm. But sometimes in some places, we really need to have the Latin of caveat emptor, which is buyer beware. And I'm
Yeah.
sorry to sort of say that. It's a little bit of like tough love, but you've got to be your own best advocate. You've got to get your information. You've got to know what you're getting yourself into. And it may be great, but you've got to do that due diligence. So in terms of on the law side, I can't answer everybody's statute of limitations right now, but there are doctrines that help when you've recently discovered your injury.
Thank you. And kind of a similar question, and we've maybe even heard this earlier in other parts of today's webinar, but a lot of us aren't actually told what the risk factors of vaginal birth are. So this severe tear is brand new information for a lot of people. So, this person in the chat was saying they don't necessarily feel like their right to make decisions was violated, but that right of informed consent, is questionable. And what's
Mhm.
your opinion on that? Does that make litigation impossible? Because it seems like such a gray area in the United States.
It's going to be really on a case by case basis, and it's going to depend for litigation perspective on your jurisdiction. Because, for example, there have been cases out there where people might have said, "Oh, this is, you're never going to win that in court," and they've
Mhm.
won. For example, there's a case in California about informed refusal, where a woman was not told why the doctor wanted to do a pap smear, and she was like, "Well, I just don't want that. I just don't want something invasive," whatever the reasoning was. But then she got cervical cancer and she died. And her family, young children, and her husband argued that she didn't have proper informed refusal. And you know what? They won. So there's a lot, so the rule was, okay, you have to have proper informed refusal, including why we're doing this procedure or these kinds of things. So there's a lot, there's a lot there. And the other thing that you'll see in these books and these films is that, again, fortunately or unfortunately, there are different methods of supporting birth in the United States and also around the world. And you have to understand these systems that have grown up over time, the power dynamics, and what is sort of, fish water. What is the water in which you may choose to swim? And you can really get educated about that. But it is a little bit of early 70s, our bodies ourselves. You're going to need to learn it for yourself. You could litigate that you weren't properly informed. You're going to need to find a lawyer. And the question would be, how many, what are your damages? Because a lot of lawyers who work on contingency fees are going to say, it's going to take me, $500,000 to litigate this case, knowing experts, trial costs, et cetera, et cetera. And if the best case scenario that this lawyer thinks is maybe I could get you $50,000, the economics of that aren't going to make sense. Now, is it possible that pro bono organizations and ACLU, a Center for Reproductive Rights, could there be a Center for Birth Rights staffed by, umpteen lawyers who are funded by the organization who just litigate this and it's not about the money, it's about the rights? Sure. I am not aware that that currently exists.
Okay. Well, this was very helpful. Thank you so much. I think this is an area that a lot of people don't know about, the intersection of medicine and law and ethics. So thank you, Dr. Cantor, and thank you so much, Dr. Moise. Pelvic health is definitely something I was unaware of before I had my daughter, and it has changed my life. So I agree with you that everybody with a pelvic floor should be doing pelvic floor physical therapy. Thank you both. We are
Thank
going
you.
to skip our next break for the sake of time since we are so close to the end here. Thank you everybody for sticking with us this far.